It's a Northwest Lifestyle Weekend on Como News. Here's Tom Hutler and Shannon O'Kelly with more IRG Health Talk.
All right, our next guest is Dr. Christopher Wahl, orthopedic surgeon, trained in sports medicine, arthroscopy, and trauma. And we're talking about ACL revisions. Now, ACL, of course, we talked about this with both Bruce Irvin and Marquise Blair of the Seahawks. They tore ACLs, which we assume to be for the first time. They're going to have that season-ending surgery, but tearing it for a second time? I'm going to talk about what goes on there, Shannon. Is this as terrible as it sounds?
The percentages are pretty significant, particularly in high-level athletes and high-level people with increased activity. So you can re-tear your ACL that's been repaired before. But the good news is the revision techniques and the process and the knowledge and the intervention is much improved, so you can have a successful revision. That's what Dr. Christopher Wahl is going to talk about today, is that revision process. How do you do it? What are the choices, et cetera, et cetera.
All right, here's Dr. Wahl and Shannon O'Kelly.
Dr. Wahl, welcome to Health Talk. How are you?
I'm doing great, Shannon. Thanks for having me.
Well, thanks for joining us. We're going to talk about ACL revisions. But before we get into ACL revisions, let's talk about your practice. What is your area in your practice as an orthopedic surgeon that you like to focus on?
It's primarily sports medicine, knee and shoulder primarily, although we do ankle and elbow and some other injuries as well. Our practice has kind of evolved into taking care of a lot of the more complex sports injuries, revision work, recurrent dislocations that have failed surgeries before, and then multi-ligament reconstructions of people who've injured more than one ligament in the knee at one time.
So we're going to talk about a revision. We're actually going to talk about ACL revisions, or a revision of the ACL, which was previously reconstructed. Before we get into that, describe the anatomy of the knee, and let's specifically talk about the ACL and why it is so important.
Yeah, so the anterior cruciate ligament is a really complex ligament. It has two sort of major roles in the knee. It helps control the forward motion of the tibia or lower leg bone under the femur, and it also helps control the rotation of that bone. So the knee is not just a simple hinge joint. It has sort of a complex motion. And the way nature got around that, or evolution, or whatever you believe in, is that the ligament is sort of a fan shape on one side. It's got a broad insertion on the femoral side of the bone. It has a twist, and then it fans out on the tibial side of the bone. And that microanatomy of those fibers is what allows it to do what it does so well.
And the anterior cruciate passes alongside the posterior cruciate, and maybe you can describe the posterior cruciate. And I want to talk about why the ACL is so prone to being torn versus the PCL, and then we'll get into the revision aspect of it.
Yeah, so they call them the cruciates because they both sit sort of right in the center of the knee, and they cross. The posterior cruciate ligament runs from the front to the back, and the anterior cruciate ligament runs from the back to the front if you're starting from the femoral side down to the tibial side. And they work sort of in concert together. The ACL is more commonly torn because, first of all, it's a smaller ligament, so it's much more prone to tearing. It doesn't heal in the way that even partial PCL tears can tear, because the ACL is sort of bathed in the joint fluid. So if you do get partial tears, those two ends of the ligament aren't sort of captured in an environment that can heal on its own.
And is that related to blood flow to the ACL, just the lack of blood flow?
It does. As a general rule, ligaments have not a whole lot of cells and not a particularly copious blood flow, which are the sort of two key ingredients you need for any tissue to heal.
And if I tear my ACL, I'm going to, usually I know I tore it, I feel it, I've got instability or hypermobility of the joint. Usually it's a mechanism of non-contact. We've seen it on TV. Maybe you can describe the injury mechanism.
Yeah, so most ACL tears occur as a combination of both a rapid deceleration or cut that imparts a rotational and translational force on the knee. So basically, as you the leg or tibia is moving forward and rotating, it essentially exceeds the tensile strength on the ligament, and the ligament tears. And
when it tears, usually the patient will describe, a lot of times they'll feel something, they'll feel a pop, there's some immediate swelling, and then again some instability. They have difficulty weight bearing if it's a significant tear. Is that correct?
Yeah, usually it's variable. So what's interesting is that a lot of people can tear their anterior cruciate ligament and have relative stability of the knee. And there are a lot of people who have torn ACLs who are still very functional, even at certain athletic sports. Other people tear their anterior cruciate ligament and can't even perform normal daily functional activities without their knee shifting or giving way, which kind of gets into our revision and techniques and things like that.
Back with Dr. Christopher Wahl and Shannon O'Kelly after this time out on Como.
It's a Northwest Lifestyle Weekend on Como News. Now back to IRG's Health Talk.
We continue our conversation with Dr. Christopher Wahl and Shannon O'Kelly talking about the ACL.
Dr. Wahl, again, thank you so much for taking time to join us in Health Talk. We're talking about ACL revisions. So I've torn my ACL. I have it repaired. How would I re-tear it, and why would I require a revision?
Well, that's the first thing we got to figure out when these tears occur is when they re-tear, which is actually more common than you'd think. The first thing you got to figure out if you're thinking about a revision is what were the factors that led to the re-tears. That can be anything from the graft that was used. Age and activity level play a big role. Younger people who have a higher exposure to cutting sports have a much higher re-tear rate. And then there's innate factors of the knee that predispose people, particularly females, to having tears more frequently than males do. So the thing you have to figure out as a surgeon doing a revision is, and that's what makes these cases interesting, is it's a puzzle. You got to figure out what were the factors that led to the tear, and how can I mitigate those factors in redoing the surgery so that these same things don't occur again.
Is there a percentage of people, is there a stat, how many people experience a re-tear and need a revision?
Sure, but it's totally dependent on what you do. When we talk to patients, oftentimes surgeons will quote that the success rates are 80 to 90%, which is not false. It's just that those results are embellished by the fact that we do so many ACL reconstructions in people who really don't use their ACL. If you look at elite level athletes, for instance, at the high school, college, or NFL level, as many as 67% are successful, and even if you look at skilled players, for instance, in football, 43% of skilled players can play at the same or higher level of activity they did before. So the short version is if you're using your ACL, you have a much higher chance of having a re-tear or re-injury to it.
Okay, and as a surgeon, you talked about it's kind of like a puzzle. Describe how you perform one of these revisions and what your options are.
I think the two most important things, and the number one role for re-tears, number 1 and 2, I would say, are either tunnel technique from the first surgery that wasn't ideal, and that can lead to a re-tear, and or poor graft choice. In terms of revising these, we have to address both those issues, whether it means redoing the tunnels or bone grafting the tunnels and coming back and redoing the surgery, and then choosing a graft that is a better graft. And probably the latest thing that's come about, which is really exciting and I think is really made a big difference, is doing sort of an auxiliary ligament reconstruction on the outside part of the knee, which is further away from the center of rotation in the knee, that helps control the rotation. It basically helps the reconstructed graft control the rotation in a way that just reconstructing the ACL can't do. And that's been something that's a real mainstay in our treatment. It's called the anterolateral ligament reconstruction.
So you're actually revising the ACL graft on the inside of the knee, but in addition, you're putting a graft on the outside to help support that interior or that internal ACL.
Correct. It's a rotational control. And it's not a new idea, actually. At the very beginning of ACL surgery, there were some, in the late 1970s and early 80s, there were some kind of heretical surgeons who were saying we don't need to reconstruct the ligament on the inside of the knee. We just need to control the rotation. So a lot of these reconstruction techniques for this anterolateral ligament are based on work and actually success that was had at that time when people who weren't even rebuilding the ACL, they were just adding these extra articular or lateral side of the knee reconstructions to control the rotation, and those patients actually did quite well.
Well, great options for those patients out there that have had an ACL reconstructed but tear it. There is options for revisions. That's great information. Dr. Wahl, thank you so much for your time. Great information.
Thanks for having me, Shannon. You guys have a great day. Be safe.
Dr. Christopher Wahl, more information at opaortho.com. And Shannon, it's good to know that if you happen to tear an ACL and then happen to do it again, there's hope.
There is hope, and there's a lot of athletes playing professionally and collegiately and even in high school that have experienced these, and they come back and they do fine and they get back to activity.
All right, thanks again to Dr. Christopher Wahl. Back with our final segment next on Como.